Testing, testing. Hello. This is a microphone. Testing, testing. This is a microphone. Testing, testing, testing. Let's go with the second row by the pole. Cool, thanks.
I'd rather show this Michael. I can stare at you.
Yeah. I waved to him up in the front.
Only when I'm up there. When I'm up there.
So is anyone introducing you at all?
Yes, I have my present.
Okay, perfect. This microphone is on and ready, so whenever you want to start talking, go for it, and then you can leave it.
Got that?
Perfect.
Thank you.
For you.
And Danny, you can sit there while I'm talking because I'm sitting.
Oh, sure. Okay. Katie, do you want to sit in the front? Is that your white jacket that I can sit on?
That's microphone.
That's my glass. Okay. Maybe, or Katie, you can stay there. I'll sit right in front of you. Perfect. So right now this mic is on mute. So right before you start, you can turn it up.
How do I turn it up?
Right at the top here. You see how it's mute?
I just push.
Except.
Okay. I have a feeling you've done this before.
A million times. Yeah. Right. There you are. So yeah, whenever you're ready, you just flip that switch. And then whenever you're done, you just flip it back off. And you can leave the mic right here, and I'll be here to help clean up. So we are all set. We're just waiting for folks to come. The recording, one thing to note with that is that the only audio that gets recorded is what's said in the microphone. So when people ask questions, you need to repeat it.
Maybe you can remind me.
I will. I will totally do that. You wouldn't be the first one to forget that. All right, perfect.
Danny, do you want to put this on the
No, that's the second. First book.
Oh, sorry, she said that I could. Well, she's talking the whole time. Do you want to sit anytime? Yeah. In the meantime.
I know it. All right. Is it? I do know that. Yep, we had a long conversation. We're going to launch.
Good afternoon, everybody. Welcome. Hi there. I'm Michael Resnick from the Division of General Pediatrics and Adolescent Health here at the University of Minnesota. It is my delight to welcome you to this, the annual Morris Bluhm Memorial Lecture. This lectureship was established here at the University of Minnesota in 2002 by Dr. Robert Bluhm, now here with his spouse, Dr. Michael Bluhm, both from Johns Hopkins University. For those of you who don't know Bob Bluhm, he began and directed the Division of General Pediatrics and Adolescent Health beginning in 1978, leading that effort until 2004, What he did during that time was to move this campus from having virtually no adolescent health presence whatsoever to creating a strong and vibrant intercollegiate and interdisciplinary leadership training program in child and adolescent health, which continues to thrive today. So it's just great to have you back here again. And we're so appreciative of this lectureship. When it was established back in 2002, Bob said that the intent was to assure that there would always be fabulous talent and fabulous voices speaking here in this setting about the health and the well-being of young people. So the fabulous talent and voice that we have this year is Dr. Sarah Brown, who is the CEO of the National Campaign to Prevent Teen and Unplanned Pregnancy, based in Washington, D.C. Both Sarah and the National Campaign have won virtually every relevant award you can think of. We're waiting for the Nobel Prize to be announced, but those awards are really reflective of the fact that this organization has been able to work so effectively in creating dialogue and debate and finding common ground among some of the most contentious issues that we face here in the United States. Before coming to the National Campaign and founding it in 1996, Sarah was a senior researcher and advisor to the Institute of Medicine. So it is great to have you here, and welcome to the lectureship.
Good afternoon, everybody, and thank you for allowing me to leave Washington, D.C. That's always my greatest pleasure. As the plane lifts off, you know, I just sort of feel the stress and the craziness melt away. I am honored to be here, truly. Michael Resnick and his lovely wife, Linda, who's also here, and Bob Bluhm and his wife, Michael, who's also here, have been good friends of my family's for a number of years, mentors, colleagues, inspirations, and to be here with all of you is a very special pleasure. And I'm particularly pleased to be at a session that honors Bob's father. I never met him, but I want to read you what was said about him when this memorial lectureship was set up. Morris Bluhm was born in December 1912 and was orphaned at the age of 5 as a consequence of the great flu pandemic of 1918. Taken in by his aunt and uncle, he completed high school, went to Long Island University, and subsequently to the Buffalo University, now the State University of New York at Buffalo, where he trained in dentistry. After serving in the Army during the Second World War, he returned to New York to open an office in Queens and continued to practice in the same location until his retirement at the age of 77. Mo, as he was known, had 2 children, Nancy and our wonderful Bob with us today. It was Bob Bluhm who came to Minnesota as a pediatric resident in 1973 and remained on faculty, establishing, as Michael Resnick just described, the Adolescent Health Program and chairing the Division of General Pediatrics and Adolescent Health from 1978 to 2004, at which point he moved to Johns Hopkins, which is wonderful for those of us who live in Washington, because he and his family are now much closer. We love that. Your loss was our gain. Morris Bluhm had numerous distinguishing characteristics, but first among them was his deep love of learning and a commitment to science and research. It was because of that commitment that upon his death, his children and extended family established the Morris Bluhm Memorial Lecture to assure that Minnesota will always have the opportunity to be enriched by the greatest minds in adolescent health. So again, I'm so very pleased to be here. We're going to spend an hour, I think, a little less than that together. And as you see, we're going to be talking a little bit about birth control, contraception, and I hope it's an engaging and fun time for you. Please interrupt, raise your hand, ask questions. I don't want this to be any drier than it sort of might be with all these slides and so forth. Here is the required disclosure form. My life is so dull, I have nothing to disclose. I really just can't think of a thing. We are going to talk together about 3 issues today: overall trends in teen pregnancies and births, and particularly in unintended pregnancy among young adults. We're going to talk about a parallel universe that our group has created called Bedsider.org, which some of you may know a bit about. And I want to finish by talking a little bit about current controversies in birth control. But I think the underlying theme of all this that Bob and I chatted about a couple of weeks ago is that my organization, indeed, just speaking only for me, is that I think our sweet spot is moving research into action. In all my years at the Institute of Medicine, I love the research part. I love figuring it out, especially with committees and colleagues who were so smart. But what I always found limiting is that the sort of, well, what are we going to do about this now, was never quite on the table. And when we started the campaign in 1996, the whole purpose was to try to say, okay, we know a bunch of stuff, but what are we going to do about it? And it's been great fun ever since. Just to sort of situate us, the U.S. has extremely high rates of teen pregnancy and birth. These data are largely from sort of 2009, a little bit of difference in some of these, and some of these things develop these underlying statistics a slightly different way, but I think you get the picture. Here we have Switzerland, Japan, Netherlands, and then you see on the bottom the United States. Actually, the country with the lowest rate of teen pregnancy and birth is not on this, and that is, what is that? Lowest rate in the world. South Korea. South Korea. And I'm not sure why that's on this. I think we say it's our principal trading partners, but of course South Korea is that too. I'm going to have to ask the WHO why South Korea is not on it. So this slide, incidentally, reflects the huge progress that the U.S. has made, this large bar. It shows that even with all the declines, which I'll get to in 2 seconds, we are still major outliers in adolescent pregnancy and birth when we compare ourselves to other developed nations. I could spend hours sort of mulling over this particular line graph. It simply shows the odyssey over a number of years, starting in 1940, on the U.S. teen birth rate. And even though people talk about how high it is, as you can see, it was quite a bit higher in the immediate post-war period. The high mark in the 20th century is in 1950, I think it's 3. Maybe I can't quite draw my eye down there, of 96.3 births per 1,000 adolescents 15 to 19. So, we've been on a steady decline, and then for reasons that no one to this day can explain, please let me know if anybody can. I'm on a quest for this. The teen birth rate went up quite dramatically in the late 80s, very suddenly, as you see there. And now we have, after a little blip just a couple of years ago, we're now back on this steady decline since the post-war period. But the important thing to understand about this sort of macro picture is that most of the teen births, pregnancies, not so much pregnancies, but certainly births, in that immediate post-war period were to married teenagers. The face of teen birth now is essentially to unmarried teenagers. And that, as I said, we could talk about that for a very long time, but that's the principal difference in how we feel about it. People didn't wring their hands and have national commissions and public service campaigns in the 50s about adolescent births because those births were largely in marriage. Now, a number of them were conceived outside of marriage, but do we even know the concept of shotgun weddings? Does that still exist in our public consciousness? I think that that's what was going on to some extent there. Now, just to sort of juxtapose pregnancy rates on top of this, although I don't have it going back as far, this starts in 1972. And there's that peak, went up in the 80s. The important thing about this, because I don't want to make this too dorky or complicated, the important thing here is that the reason the teen birth rate has gone down is not because of ever higher levels of abortion to adolescents. It has gone down because of decline in the underlying pregnancy rate. Fewer teens are getting pregnant and having babies. It's not that we have the same level or even more teens getting pregnant but having ever higher levels of abortion. We've done this, I think, the right way. That is preventing the pregnancies in the first place. And we could also look at abortion data, but I thought we might take a pass on that. Now, the interesting question, of course, is why the progress? As we often say in our group, there are only two ways to prevent a pregnancy amongst an adolescent girl or anybody of any age, and that is you either don't have sex or you use very good contraception pretty much all the time. It has to be some combination of those two. So we say that all the time. It's been less sex and more contraception, principally more contraception. Although we could fill this room with people who love to argue about whether it's 70% contraception and 30% delay of first sex. Is it 40, 60, is it whatever? It's an unanswerable question given the data sets we have, but it's still important. I think generally contraception, particularly since 2000, has been the principal driver of the decline in the teen birth rate. But the real question is, let's say it's 50-50, just for sake of argument. Why are young people being more cautious? Whether it's less sex, which is more cautious, or better contraception, which is more cautious. And that is where our sort of data and analytic ability really comes a cropper. Because we just can't tie neatly in cause and effect. And I cannot tell you how many theories and perspectives are put forward on this. Certainly people think that all the activism, particularly in the 1990s, about AIDS, HIV, and sexually transmitted infections caused particularly boys, who now were at risk, as the girls have always been at risk, were a little more attentive, and indeed we did see condom use increase in certain parts of this secular decline. A number of people say, well, there's been so much more information on the internet now. You know, maybe you couldn't get it in the 50s, what you needed to know about sex and risk and pregnancy, but you sure can. You know, if you can't find it in the book, you can sure find it online in 1 nanosecond. Maybe that had something to do with it. I happen to think social norms have had a huge amount to do with this. There does seem to be a general common view increasingly that adolescence is for education and growing up and not so much for childbearing. These declines have been in every state, every racial and ethnic group, every income group, which means it's probably not the result of a particular program or a new contraceptive device or a public service campaign or, for that matter, the efforts of our group or any others. It is so profound and so widespread that I happen to think it's had something to do with a change of social norms. Advocacy, for sure. There have been a lot of groups working on these issues, including very distinguished people here in this state, working on the subject of adolescent pregnancy for a long time. We have a new funding stream of over $100 million at the federal level for programs in states and communities, some of which is being spent in this state. There's MTV's Teen Mom and 16 and Pregnant, which I think is very important more recently. We do a lot of work with them. And these two franchises are being continued, and we're adding a new one at MTV called Virgins. It's going to be I think it's a sitcom, please, of 3 20-year-old young women in their 20s who are virgins, and we're now going to learn why. Can't wait, you know, can't wait. Anyway, what else? I mean, I invite you. Why do we see this just remarkable decline? Through recessions, through not, why do we see this in adolescent pregnancies and births? I'm not going to put you on the spot, but if anybody wants to contribute his or her own particular explanation, I'm wide open to it. I get asked this all the time. Yes?
It could be because kids' lives are so much more structured now.
Huh.
Like, it seems like in the old days, there was a lot more free time for kids that wasn't coordinated and, supervised by adults. And now, if you're active, your time's coordinated and adults are there.
That's why God. What is it? That's why God invented after-school programs. Is that it? Something like that, or soccer or something? Yeah, that's interesting. Yeah.
I'm also fascinated. I'm learning this with us, and they have an accent, so we try to shout it out. I'm also intrigued when you mentioned South Korea. I'm intrigued by the work that Sean Santelli and some folks has been doing internationally and how health equity and difference in income, the widest the gap of income in family, the more pregnancies you have, and how have an influence on that. It could be activism on education and for education and hope and the concept of health equity. I don't think the United States per se has changed much to influence that way, but I wonder, particularly in salary, in distribution, in equity, but I wonder if the community activism or how that can be.
Well, the question I'm asked the second most often, besides why the rate's going down, is why does the U.S. have rates higher than all these other countries? And if I were recommending a PhD thesis for maybe not just one person, because it's a huge issue, I think real scholarship on international differences is deeply, deeply needed. There has been some work done, but I've spent some time with that information with a number of colleagues, and it's okay. A lot of it's quite dated, and there's very little that really talks about social norms. It tends to look more at sort of things we can count, like income inequality or what other things like that. And I think it's a very important question. It's hard to get the data. People just measure things differently and so on and so forth. I don't really know the answer, but I commend it. I mean, I can tell you what I say to the press with blah, 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 but in the privacy of the family, I'll tell you I'm not really sure about why the rates are lower. Not as sure as I think we should be. So there's been a lot of good news in declines in teen pregnancies and birth. But we have come to understand at our group that even so, this country is very confused about a lot of this. And here are a few sources of the confusion. Most people think that teen pregnancy is all about kids in middle school and high school. And I always have this feeling when I'm talking with a group, let's say a community group about teen pregnancy, I can just feel that they have this image in their mind of the 16-year-old girl in the back row or that poor 8th grader that became pregnant and no one even knew she was having sex, and what about this and what about that? We also understand that most people think that most abortions are to teens. People just talk all the time about, especially if you go to abortion meetings, please don't, where everybody's fighting and arguing and so forth. It's all about those teens and all their abortions and so forth. And in fact, 2/3 of adolescent pregnancies are amongst 18 and 19-year-olds, and these fluctuations have been driven by those older teens. And what percent of abortions are to teens? I've already given you a clue that it's less than people say. What is it? Does anybody know? It's 17%. I see heads nodding, so you all probably know this because you're medical professionals, but the average bear thinks it's 50, 60, whatever. So we have a kind of a distorted understanding of where adolescents face in this larger issue of unplanned, unintended pregnancy, of which teen pregnancy is simply a subset. Teens, in fact, are the only ones making any progress. Not only are they not the source of the problem, they're the only ones making progress. These data show comparisons of 2001 and 2008. And if you'll see, the stacks 2 and 3 show the declines amongst 18 and 19-year-olds as well as 20, 24-year-olds. But we see increases overall for sure. But among 20 to 24-year-olds, pregnancy up, 20 to 25 up. Even the old ladies, 30 to 44, up. Unintended pregnancy, I'm not talking about total pregnancy, I'm just talking about those that women themselves report as unintended. And at a session I was just at this morning with Michael Resnick, one of the participants asked, I think, the key question, which is, might it be that unintended pregnancy amongst the 20 to 24-year-olds will soon start going down as these more careful, apparently, prudent, apparently, teens move in to these early stages of the early 20s. And we were looking at some data just yesterday in the office, and we saw some things that suggested that might be true, that these teens who, for whatever reason, have decided to be a bit more cautious at the margins, as they get into 20, 21, 22, we may see that fourth stack of 20 to 24, rather than showing an increase, we might see decreases. Understand the unintended pregnancy rate, the overall, particularly for non-teens, has been flat or getting worse for a couple of decades. The only bright spot has been the teens. In 1970, our organization, the National Campaign to Prevent Teen Pregnancy at the time, expanded to include this problem we kept seeing, which is that the teens were doing fine and the young adults in their 20s weren't doing so fine, especially the single young adults. And so being dutiful people and sort of intellectually organized, we said, well, we know their rates are high, particularly among single young adults in their 20s, but we know teens. We've spent 10 years, and some of us forever, trying to kind of understand adolescence. But now, great, we get to go on to something new, which is to understand what's going on with these young adults, 20 to 24, 28, whatever. And we found the most extraordinary thing, which was how little data there are on this older population, these 20-somethings. People have been writing about teen pregnancy forever. It's like a cottage industry. And some of the people in this room have contributed to that, including me. But so that's great, and we've been making progress. But then you say, well, where's the parallel body of information about sort of the sexual knowledge, attitudes, practices, intentions, blah, 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 of people who were 22, 24, including, needless to say, young men as well as young women. And we were so discouraged by it, and I think really puzzled. I still don't entirely understand why that's true. We went ahead and did a relatively modest, but I think intensely interesting survey, a nationally representative survey of about, I think it was 1,800 young men and women. We did this with the wonderful Guttmacher Institute. We published the findings in the, I don't know, about 4 or 5 years ago as the fog zone. And I tell people this, and I always sound like I'm self-promoting, but believe me, I'm not. I think it's one of the most interesting sets of findings in this field that I have seen. I would sit there, at night looking at sort of some of the first runs, and I just go, how can this be? I was just amazed by it. And I'm going to share a few of the findings with you just to show you, I think, the kind of thing that at least I found interesting and that I hope you will too. This is the report has lots of tables and lots of stuff. I'm just going to show you a few. Most of the vast majority of the young adults in this survey, one of the screening criteria to get them in was, are you trying to become pregnant or cause a pregnancy in the next year? And if the answer is yes, they were ruled out of the sample. We just wanted people who said, I'm not trying to get pregnant or cause a pregnancy. So we had 1,800 who all said that, men and women. And then we asked them about were they in a sexual relationship or had been in the last few months, blah, blah, blah. Anyway, so we had a sample then, a lot of the group, who were unmarried, said they didn't want to get pregnant, and were in a sexual relationship. It's the vast majority. And the question was, how are you doing on contraceptive use? And it was very carefully defined as to what non-use is and what inconsistent or improper use over the previous 3 months. And here's your explanation as to why we have high levels of unintended pregnancy. If you look at the first bar, we have 43% who are either not using contraception at all, or they're using it poorly. Missing pills, only using condoms some of the time, but not all the time. You can imagine the criteria. When you look at the 18 and 19-year-olds, we're at essentially 50%. They said they didn't want to become pregnant or cause a pregnancy. The pale blue is not using anything at all, and the maroon is inconsistent use. So there's no mystery as to why we have these high levels of unintended pregnancy. It's not 10%. It's not, 14%. It's, in some breakdowns, it's essentially half. And what's interesting, or even more interesting to me, is that when we ask people how important it is it to you not to become pregnant or cause a pregnancy, there was one, it was a five-point Likert scale, so you could say very important, somewhat important, middle, Even on the ones who said it's very important that I not become pregnant or cause a pregnancy, 15% were not using any contraception, and a quarter of them were using something but not in any way that would provide strong protection. Oh my goodness. We then asked some knowledge questions. And I want to assure you, I don't have them with me, but they were quite simple questions. They were not gotcha questions. They weren't looking for that little nugget of information about the contraceptive patch that only you guys know. These were sort of straightforward knowledge questions. I recall there was something like 18. The periwinkle blue is asking men and women how much they know about the pill. And it wasn't, do you know a lot? Do you know a little? Well, as you see, 78% of the men say they know little or nothing about the pill. 45% of the women said that as well, and we went back and looked, and a lot of those women were pill users or had used the pill in the last year. I was stunned by the condom numbers. 29% of men said they knew little or nothing about condoms. This despite years of HIV, AIDS, STD, serious, and I think in many instances quite good condom education. 32% of the women said the same thing. Little or nothing. But then, wait for it, do you know everything you need to know to prevent pregnancy? Yes. 89% of the men and 91% of the women. So we knew, and I just gave you a couple about pill and condom, and there were lots of knowledge questions and all. It's too complicated. But in essence, they have very imperfect knowledge, but they think they know enough. So it means it's even harder to it's hard to get through to people who don't know that they don't know or don't know enough. Although we talked about this as a group a lot. You know, a lot of these young people had had some form of sex education. That was one of the things that we asked about. But, you know, you might have had it in 10th grade. Let's say it was terrific. You know, you all taught it. Now you're 24 and you're in a bar and, you know, things are looking good. How much do you remember? How much do you remember about what you learned in 10th grade? I mean, maybe you do, but maybe you don't. And so I think the great faith we put in sex education, even if it's good, is not necessarily helping these young adults who are leading quite sexual lives, but apparently don't know very much. No offense. Here's another one. About 1 in 5 of these single young adults who said they were not seeking pregnancy to become pregnant, both men and women said it was quite likely or extremely likely that they would have unprotected sex in the next 3 months. So in other words, it's not just that they're sort of reporting it in retrospect of, oh, yeah, well, you know, things happen and yikes, but yeah. They're also saying, yeah, that's what happens. I'd say it's likely that I'll have unprotected sex. But this was my favorite. I think it's my last graph of this study. We read to them, or some paper and pencil, it says, it doesn't matter if you use birth control or not. When it's your time to get pregnant, it will happen. Well, about 49% of the 18 to 19-year-olds either agree strongly or some would agree. You know, 41% of the 25 to 29-year-olds. Now, we did a lot more work in this area. I mean, what is it? There's this thing of birth control doesn't work, not really. And as someone said this morning, well, you know, if you've had some friends who've gotten pregnant when they said they were using the pill, of course, they weren't using it correctly. So now the pill doesn't work. And then you have a friend who was using the patch, and she got pregnant. And more importantly, you have had unprotected sex several times in your life, and you haven't gotten pregnant, or maybe you did, blah, blah, blah. It's like, you know, birth control, yeah, sure, maybe it works, it doesn't. Just like sometimes that's just what happens. So there we are. This was my favorite. This is when I sat, you know, and I just went, WTF, you know, what are we going to do about this? Because I just thought, you know, for all the everything and all the work. And so the real question was, you know, what can the campaign do? That was our question. We were interested in learning this just for the nation, and people download this report all the time. I think we're up to something like 15,000. But the real question for us was, what are we going to do? And we're just a small group, so, you know, we don't run programs, and we're not in clinics and schools, and the question was, what could we do? So a couple of us went and collapsed on the lap of a very cool design firm in the Bay Area called IDEO. Does anybody know about IDEO? One. Bless you. Well, they've done a lot internationally, too. They grew out of the product design community at Stanford University, and they started out by doing literally product design. You know, like their signature thing was they redesigned a grocery cart. It's very cool. And then about 15 or 20 years ago, the people who founded it, these Kelly brothers, they said, why can't we bring design thinking to social problems, just the way we do to grocery carts? We try and figure out what's going on and what's wrong. And so they have worked with CDC on obesity control. They've worked with the Edna McConnell Clark Foundation on early childhood education, and a number of others. And so they were very interested in this. And I went out there literally one day and said, we have really high rates of unintended pregnancy, poor contraceptive use among single young adults who say they don't want to get pregnant. What are we going to do? And what they did is they worked with us to create a parallel universe that is called Bedsider.org. And I would suggest to you, my fondest hope is that you'll find this interesting enough that you might find ways to use it in your own practice with your own patients here, in community, and so forth. This is designed for sexually active young women. And men are mentioned some, but this is for women. It's very sexual. It's very funny. It's very informal. It's designed to travel with women on their contraceptive journey. Here's what IDEO said to me after they'd been out in the field for a few months. They said, you know what's going on in birth control now? I said, please, tell me, what? They said, it's as though you were fighting obesity and you went to a doctor's office or a clinic office and they handed you a pamphlet that gave you the caloric count of all the different foods. And they gave you, they weighed you and they said, you really need to lose 50 pounds. Here's the calorie count. Here's some tips. Come back and see me in a year, and I hope you've lost 40 or 50 pounds. Nobody would do that in obesity work. We understand that it's a journey. It's a daily decision. It's an immensely complicated process of learning, understanding, changing behavior, sometimes in big ways, sometimes in small ways, peer support, family norms, cultural values. And they said, none of that is in family planning. You go to a clinic, they give you a pill, or they give you whatever they're going to give you, and they say, see you in a year. Or maybe they didn't say that now because all of you decided we don't need pap smears every year, so we'll see you in 2 years. Hope that works out for you. And so what IDEO said is we have to design something that sticks with women all along the way. It's their girlfriend. It's their buddy. It's who they talk to. And it has many, many parts to it. This is where people hang out the most. It's every method. It's on the screen. It looks kind of dull, but it's very. These are very. The production value of this is very high. It's very beautiful. Does anybody want to guess what the cork is? Bob Bluhm?
Probably close to prayer.
Right, it's withdrawal. Yeah. And the padlock says no, not yet. We could bring this up live, but I just even tried that this morning. It's a little hard, but I'm just showing you a few screenshots. You can select any 3 methods and get these very fun things that compare them by cost, accessibility, side effects, so forth. I'm going to show, with Danny's help, 2 videos that are on Bedsider. It's very interactive and it's very cool. The first thing we're going to look at is a fact or fiction video, and there are 50 of these. This is just one I happen to like, and women cruise around them, and they're on every topic you can think of. And this one is on the NuvaRing.
Like with the NuvaRing, I heard that it comes out when you're doing it. I heard that this girl who was like a friend of my friend and her boyfriend were having sex and her NuvaRing went flying out. Literally. Boing. And he was like, whoa, what was that? Does that happen?
Well, there is a nugget of truth to that because the NuvaRing can
Some
fall
of you may know her.
out, but it certainly wouldn't fly out. Now, if it does fall out, simply rinse it with cool water and replace it in the vagina within 3 hours. Some women worry that they may have the NuvaRing in the wrong way, but if it's in and you can't feel it in, then it's in right.
So we have those on everything. Everything could be, a guy says condoms are too small for him. It's what do you do if sex hurts? Just every little thing, these little things that IDEO created.
Right now I'm a hostess.
And then real people talking. This is a real person.
Because my life is a little bit hectic and we all need money. But what I want to do is I want to pursue modeling in the future. When I first got the NuvaRing, I was with my gynecologist and I was just given a sample. And, I went home and I took it and I showed my mom and I was like, what the hell is this? Like, what do I do? I know that the gynecologist said, oh yeah, you just stick it in your vag, let it sit there for 3 weeks, and then, take it out at the end of the 3 weeks. I was like, I'll just give it a try and see. And, I went into the bathroom and I was sitting there looking at it, took it out of the package, like bending it and, pulling on it to see if it breaks or anything like that. And then, you look down at your crotch and you're wondering, is this going to fit in there? Is it going to feel weird? Is it going to move around? Am I going to notice it? So then I took it, and I think the first time because now that I have it down to a science as to how to get it in, I'm like a genius. But when I first got it,
This woman talks forever, so I'm going to spare you. She talks forever. These are real women, and we have women of all types and walks of life on these things. There are about 50 of them, and we have some men on camera talking about their partners using methods. And it's just so much fun, and people love it. And then in the last few months, we've started getting people who make their own videos and send them in to us, because I think it's so cool. So they get their friends together and they film what they did when they the first one who got an implant. And then, it's very interactive and very cool. So now we're going to go back to the PowerPoint. So there's a lot of that kind of stuff that's a lot of fun. Great. Now I'm just going that's okay. Thank you very much. We would have been here till like Christmas if I'd tried to do that. Okay. Yeah, it isn't slow to. There we are. Okay, great. Another thing that has been incredibly popular is that people can type in their zip code and get immediately a Google map of all the clinics that have at least some public financing within that zip code. And I urge you all to go back to Bedsider, look at your home zip code, and then let us know if there are any errors. We are continuing to populate this and correct it. We also you can do the same thing for LARC-friendly clinics, and you can do the same thing for emergency contraception. So it's not just Planned Parenthood or just Title X or just the health department. It's all of those databases. And we are working with a number of states to include even more clinics, health departments, and so forth. So the idea is, this is a generation that's very smartphone Google-oriented. And so there it goes. Then there are all sorts of appointment reminders and pill reminders and so forth, but they're not just, it's time to take your pill. Every day it's different. This is one from a couple of weeks ago. It says, if you're average, you produce about 25,000 quarts of saliva over a lifetime, enough to fill 2 swimming pools. Pill now. Try not to drool later. And people think they're funny and they're cute, and so they circulate them. They're very viral. Some of them are a little out there, but never mind. I'm old, so I don't read them. And then we have Frisky Fridays, which people subscribe to, and these really are out there. And we'll just say that, what is this? How to ask him to share the cost of contraception. That's one of the tamer ones. Some people don't like Frisky Friday. Can I tell a story about Yale? Does anybody love Yale, and you're going to call them? Is that okay? We're in Minnesota, right? That's okay? Okay, well, we gave a small grant to the American College of OBGYN that they re-granted on a competitive basis to some various academic departments, including the one at Yale, who wanted to try Bedsider in a variety of settings in their clinical practice. And what happened was after maybe 2 or 3 months, the clinicians at Yale got in touch with some of us and said that they thought Bedsider was a little bit too kind of out there and a little bit too kind of, I don't think the word was dirty, I think it was racy, and that they weren't sure, blah, blah, blah. And I get calls like this all the time. So I said, I really understand that. I'm 65. I mean, you can imagine how I feel about this, blah, blah, blah. And I said, what I think you really should do, though, is go ask the women in your clinic what they think about it, because this is for them, it's not for you. Well, this wonderful person, to her credit, called back 10 days later, and she said, I was wrong. This has opened my eyes. The patients loved it. This is their world. They may not have loved every part of it, but they found faces of people like them. They found stories. They found information. And this wonderful young woman said, I think I need to do some work with my colleagues, my clinicians, because we're the ones who are having the problem, not the young women. So Yale comes out smelling like a rose. To my great pride, you can't read it here. This is called Dogus interruptus, which I think is just great. Isn't that wonderful? We did not create this, although we posted on Bedsider. A couple of us went to the Ad Council a few years ago and asked them if they would do a public service multi-year campaign on Bedsider, and they agreed to do it. It's the first time they have ever done anything on contraception. And we went out and worked with one of their ad firms that works with the Ad Council, and this is the campaign they came up with. Their idea was you didn't give up on sex, don't give up on birth control. And the fulfillment, the link, is to Bedsider. So much fun. We're really excited about it. And for those of us who are interested in evidence, I want to assure you that we're very concerned about whether or not this actually changes behavior. We know it's cool, we know it's fun, we know people like it. But we are 6 months into a randomized online assessment of Bedsider to see what sort of behavioral change we can link to it. We got some early results the other day that were encouraging to me, but we'll see. It's very hard. It's a high bar to set that a website is going to change behavior. When you get up in people's faces and work with them with love over many months, sometimes you can't change behavior. So I hope we haven't set the bar too high, but we're going to be learning a lot about its impact. We'll have data out by first quarter of 2014. I'm right at the end here. I just feel a responsibility to say that meanwhile back at the ranch, while we've been having all this fun with Bedsider, and you all have been having so much fun here in Minneapolis, I'm sure, the sort of culture wars and political wars about contraception continue to rage. You probably are aware of some of that. I think you have other things on your mind and are very busy. But I just wanted to kind of walk you through how I see it. I think because I live in Washington, I'm especially sensitive to it. I get very upset about it, and of course we get involved in it. I mean, the kinds of things that have gone on, I mean, we've had Affordable Care Act controversy over whether birth control should be in any defined minimum benefits packages that insurance companies have to meet in order to be on the state exchanges. There have been objections to paying for birth control through private insurance, or using public money of any sort to pay for what some people say is a private lifestyle choice and not a core medical intervention. You may remember a couple of years ago there were hearings on the Hill about Sandra Fluke and the early days of contraception in the Affordable Care Act, no women allowed, which I thought was a low point. We had Rush Limbaugh referring to her as a slut because she was having sex and using contraception and wasn't married. We had 2 House votes last session to repeal the Public Family Planning Title X program. I think we're a little better this year. We can talk about that if you want, but it's still been remarkable. At least 8 states have cut funding for family planning, Planned Parenthood in particular. This somehow, in a variety of ways, tied up with the abortion issue, but not entirely. Some of it just hostility to family planning. And a clear, this is I think the thing that has gotten, that really got my attention. In all this ugliness and just weirdness, what I've come to realize is that many national leaders, I don't mean just elected officials, but I mean just sort of people that are out in the public square, really don't know what contraception is. They don't understand how many methods there are. They don't understand what it takes for a woman to get one of the good methods and stay on it, either personally and medically or financially. We had so many congressmen saying birth control is cheap and easy to get. I felt like saying, you're talking about you and you're talking about condoms. I understand condoms for you are cheap and easy to get, but tell me how that relates to a woman trying to get a Paragard. Do you have any idea? And then we heard this, where you can go to Walmart with your prescription for pills and it only costs $4, and you say, and how is it that that woman had a prescription? Where'd that come from? Did that just like fly out of the sky? There is very little understanding of this entire industry and sector of what contraception is, what it entails, what its benefits and risks are, how it's different from abortion, and so on and so forth. And it's become just incredibly clear once I started seeing this. So I'm just blithering on here. There's a big conflation of contraception and abortion. People often say, well, it's all just sort of the same thing. And you say, no, it isn't. One's prevention, one's intervention. They are not the same thing. If you do more prevention, you get less intervention. That is unknown and not well understood. As I mentioned, there's a lot of ignorance about what birth control does and costs. There's no good news about contraception. None. It's only the side effects get any press, only the problems. And in that, bad news loves a vacuum. So we have continued this drum roll of bad news or no news about contraception. Religion and government, we've been through that. And in particular, and I really am finally at the end here, I think what we've really had is a lack of cultural understanding of the track record and promise and contribution of contraception in American life. I think some of us who are older know about this, but a lot of sort of current media leaders and so forth, they just don't understand where we were and where we've gotten. And I think that those of us in leadership positions really have a responsibility to reacquaint American leaders and the public with the track record of contraception and its current role in American life. I feel very strongly about that. Can you tell? You know, people say, well, what am I supposed to do? Or, you know, what can we do? And, you know, there's no magic answer to these. These are cultural forces that are really very complicated and hard to deal with. But I think all of us have a responsibility to talk more about what family planning is and, of course, what it isn't, to spread the good news. I think in particular we have to explain that family planning has value in and of itself, but I think we've lost this understanding. It relates to the ability to go to school, to complete education, to have jobs, to determine family size. When there was all that raging misogyny on the Hill about contraception, I don't know why every woman on the Hill who uses contraception and the men who benefit from their partners using contraception didn't, as a group, walk out. Because it was talked about as though it was some sort of esoteric, weird stuff that no one knows about and we shouldn't have to use taxpayer dollars for it. I think we need to advocate for public support, showing that 98% of American women have used contraception at some point in their life. You know, we need to put risk and side effects into context. I always say to people, whatever side effect you're worried about, it's higher in pregnancy. So it's just, you know, that's what we're managing against with contraception. So it's risk as compared to what? It's not an unanchored number. It needs to be put in context. Oh, and there's so much more. We're going to have a big fun day in November where we're going to have a lot of celebrities shout out their birth control methods. It's going to be fabulous. Anyway, stay tuned for that. I think we're going to get Kim Kardashian to talk about contraception. It's going to be awesome. So anyway, you know, there's good stuff, but it's a very tough time. As I said, I think we've lost our way in understanding the public, larger public understanding of what contraception is and isn't, what its track record is, and what it's accomplished in American life, to say nothing of the international sphere. I am now finished with the presentation, and I welcome questions. Okay. Well, anybody else who hasn't asked a question? Oh, I'm sorry. I was supposed to repeat the questions. No other questions. Yeah. Yes.
So I know you said you're supposed to see more about the international questions, but a lot of the countries you showed aren't known for being exactly puritanical with their views on sex. Do you have any more thoughts on what the thinking is as to how their teen pregnancy rates are lower, given that it's probably not abstinence?
Yeah, the question is what accounts for the lower teen pregnancy rates, and particularly these Western European countries. You know, here's the list that people usually give when that question's really asked about why are the rates lower. First of all, they'll talk about much more extensive sex education in the schools. They'll talk about much more stable financing through healthcare systems of contraception. It's not all this, well, we have it in the clinic this week, but we don't, and maybe insurance will pay, but maybe none of that. A lot of them have national health systems that cover contraception well. There does not seem to be as much religious objection to contraception in Western Europe. And I think you're right, there's sort of a more relaxed notion about sex. The focus is on not experiencing the negative risks, unintended pregnancy, STDs, as opposed to America, who's still trying to decide whether sex is okay at all in the first place, let alone the negative risks. But, you know, I think South Korea is instructive, though, because a lot of those things don't apply in South Korea. Again, there are only two ways not to get pregnant. I think Western Europe has focused on the good contraception. But in a number of Asian countries, there's been a historical focus more on not having sex in adolescence. And we don't do that in the culture, and that's a shame factor, and that's not done. That's changing a lot as Asia has changed so much in recent years. But I think it's all those factors in Western Europe. I mean, what would you add? I don't know. More? No, nothing. It's an interesting question, but again, I think we don't have a lot of current, really good data and scholarship on these reasons, and it'd be nice if we could. Although, at the same time, people come to me and they say, "I want to tell you what's going on in Denmark," and I go, "And how is that going to help me in Newark?" I mean, I get that. You can get some principles, but I do think that that our country and culture and some of these crazy issues about contraception now really make me interested in cross-cultural comparisons, but I think we're in a uniquely weird place right now, and I'm not sure how much learning what Taiwan's doing is really going to help me. But I may be wrong about that. Dr. Bluhm.
So I would just comment, you made a statement about family planning and abortion being confounded or confabulated. The same is true with sex and childbearing. Or sex and pregnancy. Right. And I think that there needs to be a disaggregation because I think you're right. We focus on the sex part without focusing on at all pregnancy, reduction of pregnancy prevention.
I think it's a very important point, and I think of this in particular in looking at data on adolescent decision-making about sex, contraception, and so forth. And the way I will sometimes think about it in my own mind, in the privacy of my own home, is that with adolescents, there are a number of issues and myths and concerns and realities about sex. Will I have it? Will I not? Who with? Is it tonight? Or is it not? What is there sex? And then there's like the Mojave Desert. And then over here is maybe I'll become pregnant. I mean, they're two very, very different sets of considerations. And then even if I sort of see a somewhat of a link between sex and maybe contraception and pregnancy, then we now go through Death Valley, and over here is bearing children, raising families. So even if there's sort of a pregnancy, maybe kind of a baby, that they're not all seen as closely related or even causal. And so when people say, we need to talk with adolescents about how they'll be better parents if they can get through high school and have their children, I mean, maybe that works for some, but they're totally different domains of feeling, thought, knowledge, culture, and so forth. And I think the point's very well taken, though, about the sex and pregnancy just in general. People don't think they're not related in people's minds. They're separate, wholly owned subsidiaries. Yeah.
Sarah, you opened up by talking about how wonderful it was to get away from D.C. because Washington, D.C., because of all the reactivity that goes on there. I want to ask you a question about sort of the internal processes you have within the national campaign. Because my observation of your work over the last 20-plus years is that you don't just react to lightning rod issues that are going on. Your organization often leads with educating the public about issues that are new and emerging. And you raise awareness about issues where maybe there wasn't a lot of thought or dialogue. So what exactly goes on in there in terms of your staff conversations? Who are your people and your eyes and ears on the ground and so on? How does that work?
Yes, Danny said the question is sort of how does the national campaign decide what issues to work on? And so you're kind to say that sometimes we're sort of a little bit ahead of the curve. There is no formal process, but there are a few things we do think about. As a general matter, we don't tend to work on things where there are already 40 other groups working on it, because being the 41st might be nice, and if it is, we're happy to do it. But I think part of leadership is to try new things and to go where other people aren't, and there's a big need. So we think about that, and let me give you a couple of examples. We have recently gotten very interested in contraception and family planning in the U.S. military and the role of contraception and family planning in an enormous grant program administered by the Department of Education called Promise Neighborhoods. I don't know if you all know about them. There's one in Baltimore. And our observation is that in the military, there are enormous problems in contraceptive access for women. And Promise Neighborhoods do I'm not going to say nothing because that's too strong, it varies, but they do very, very little about contraception, even though the whole model is, it's the Harlem Children's Zone, sort of on a national level. We'll try and do everything they can for high-risk young people. So one of the things we're always looking for is where's something that's important but not done. Bedsider, we look to say, where is the online contraceptive support system? We spent a long time looking around, and it didn't exist. And then we thought that might be a useful thing. So I think what we try and do is work on things that we think are important but that are not known or not worked on by the people who traditionally work in this sector. We put out a report a few months ago that has gotten more press attention than almost anything we've ever done. It's called Not Yet, K-N-O-T, Yet. It's about changing trends in marriage and childbearing. And the signature finding of the study was that the average age of first marriage in the U.S. is now later than the average age of first birth in the United States. And thinking about all that that means, unintended pregnancy and family structure issues. And I don't know any other group that had sort of zeroed in on this, titanic switch in family structure and social norms in the mid-20s. So maybe that's it, Michael. Maybe it's just trying to find things that are important but sort of not already part of the mix. Maybe. Yes?
Quick question about if you have done any intentional specific evaluation about Bedsider and teams. Because to me, Bedsider is the most funky available thing that you have out there. And I use that a lot for middle and late teenagers. And I have to say that including their own grants, I call it the GPS of birth control. Because primary care, when you are like dealing with sexuality, which is usually not the training or the main thing, because it's a different spectrum when you're doing family planning. But in primary care,
Yes.
I feel this is a tool that makes you accountable because you put the pin, choose the zip code that you want to choose, and let's find a place for it. And I need to put it on as a referral piece. And it gives me a tool to follow up and me, the provider, be accountable for that. So I have.
Well, that you've made my day. That's wonderful. Yeah, may I speak candidly? Yeah. This was just a comment on using Bedsider for an adolescent clinic as opposed to sort of young adults in a primary care setting, not just family planning. One of our highest aspirations is to have family physicians in general settings, general pediatric settings, internal medicine, whatever, uses not just, the Planned Parenthood clinics. Although that's fine. I mean, that's wonderful too. Whoever wants to use it in any way, we're delighted about that. If one designs something online for minors, there are all sorts of internet requirements and sign in and parental this and parental that we did not want to do. So we say, and it's true, and we said this to all of our marketing people, design people, this is for young women 18 and over. We know that an enormous number of people who work with adolescents are using it, and we're glad about that. That's good. But that was not who it was designed for. I think we're out of time, Dr. Resnick. Am I right?
Yes, ma'am.
Thank you very much.